joiners. So thank you everyone for joining us for our second Medify webinar. We're joined by Suzanne Turner speaking about slow-release oral morphine for the treatment of opioid use disorder. Katie will introduce her and the talk a little bit. I'd like to start with a land acknowledgement. And actually the first thing I'd like to acknowledge is that we have not previously had a land acknowledgement. And so in the spirit going forward of reconciliation, I'd like to start with this, recognizing that we are spread across the province and perhaps even beyond Ontario tonight. So it would be beyond me to acknowledge the specific homelands, but I invite you to think about where you are sitting. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. These are the ancestral homelands of the Huron-Wendat, the Anishinaabeg, the Mississaugas of the Credit, the Haudenosaunee, and the Attawendarons, or Neutrals. And in Toronto, this is home to the Dish with One Spoon Treaty. Medify recognizes that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. Medify respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. Kate, I'm going to turn it over to you now to introduce Suzanne and our topic.
Great, thank you. I'm really excited to introduce Dr. Turner. So Dr. Turner is a family doctor, a low-risk obstetrics provider, and an addiction medicine physician, specializing in hospital-based addictions management and perinatal addiction medicine. So a little bit of background, Dr. Turner spent the first 10 years of her career in the inner city of Toronto. After she completed medical school training at the University of Toronto and residency training at St. Michael's Hospital, she completed a fellowship in addiction medicine at the Center for Addiction and Mental Health. She then went on to become a diplomat of the American Board of Addiction Medicine. After her training, she worked in Toronto's inner city as a comprehensive academic family physician affiliated with St. Michael's Hospital. She was the medical director of the Substance Use in Pregnancy program that provided combined addiction, psychiatric, and obstetrical care to women with substance use disorders through an innovative drop-in model. She was also one of the first inpatient addiction medicine physicians at St. Michael's Hospital. Dr. Turner has won awards for her teaching, role modeling, and her advocacy work for women with substance use disorder. So currently, Dr. Turner is an associate professor of family medicine at McMaster University and currently divides her time between full spectrum academic family medicine, inpatient addictions, and comprehensive maternity care. Her research interests center around novel treatments for substance use disorder in pregnancy. So many exciting things happening in that. So I'm very excited to welcome you and can't wait to hear what you're speaking about tonight.
Wonderful, thank you. So I'm very excited to be here tonight. I don't have any disclosures to give you. I don't receive any financial support from any of the companies that produce medications that I'm speaking about. I'm going to go over the learning objectives and also kind of give some caveats to what we'll be discussing tonight. I'd like to encourage everyone, if you have any questions, to reach out in the chat. Dr. Wyman and Katie are both monitoring that for me, and they'll stop me so that we can have more of a fulsome conversation, because this platform makes it difficult for me to know when people want to speak further. So in terms of learning about slow-release oral morphine tonight, I'd like to look at the evidence to support its use as a treatment for severe opiate use disorder. And one of the reasons that I probably feel comfortable with SROM is that it's actually been used quite a long time in pregnancy management. So far before the time that we have buprenorphine, second line was actually considered slow-release oral morphine. And we actually had a pretty pivotal trial that I'll talk about from 1999 that was a head-to-head clinical trial of methadone versus SROM in pregnancy. So I very early on in my professional experience had lots of experience prescribing SROM in pregnancy. And so when it became more mainstream to do this outside of pregnancy, I already had some experience that others might not have. We'll talk about initiation and maintenance support for SROM in the community, and we'll talk a little bit about some of the challenges that we have, and that it's a very fast-moving environment, and many of the guidelines and literature reviews that we have on the subject haven't really kept pace. And that's probably where most of the confusion around SROM comes up. And when I'm speaking to colleagues or trying to co-manage with other services, it becomes quite challenging because there's a lot of misinformation and a lot of older information in the literature, but not much that's new. And then finally, I'll talk a little bit about the utility of SROM, more in a hospitalized environment, but also for an adjuvant for those who are on methadone in the community. And we'll kind of talk about why, if you're a provider or prescriber in the community, you might receive patients on SROM, and why we may have made that decision in hospital, because often it's difficult to communicate that directly after the fact. So we'll talk a little bit about that as well. And hopefully we can go through some cases, and we can have a more fulsome discussion also about that information as well. So in reviewing the evidence to support SROM as a treatment of opiate use disorder, there's quite a lot of good information from the British Columbia Centre of Substance Use. So the BCCSU has a guideline for the clinical management of opiate use disorder that came out in 2017. And for most of us, that's probably where we first heard about SROM. Just as a joke for other people who do obstetrics, the first thing I thought was, that's a terrible name for someone who does obstetrics. The first thing I think of is spontaneous rupture of membranes. And for my other perinatal addiction docs, we're always like, are you talking about SROM or SROM? Which one are we talking about? So terrible name for those who do perinatal addictions, but a very appropriate name when you don't want to use brand names for slow release or morphine. So this trajectory basically looks at the kinds of treatments that we think about in terms of treatment intensity. Where most of us probably fit is hopefully in the middle area, looking at agonist therapy if you're a prescriber, and also maybe a bit in terms of withdrawal management and trying to persuade people in terms of safety to move more towards the middle. So in the BCCSU guidelines, they really talked about SROM being a specialist-led alternative approach, and this was largely because I think it was relatively new, and that historically there's been a lot of barriers to prescribing, mainly related to coverage on provincial formularies, but also the restriction in terms of carries, which we'll talk about later on. So really this became within the specialist-led realm, and that always we include psychosocial and residential treatment as well. But I think given that it's been several years since this has come out, we have to think about moving forward, where is SROM going to fit or continue to fit in our treatment paradigm? And that's a bit harder to answer because I think it's probably related to the province that you work in, the population you work in, and we can kind of talk about where we think it might fit in our own practices based on where we practice and the kind of populations we're seeing. So this is directly from those guidelines that say that SROM should be used in patients whom first and second line treatment options have been ineffective or contraindicated. So OAT with slow release oral morphine, ideally prescribed as once daily witness dosing, can be considered. So the initial guidelines said that you needed a Section 56 exemption, so you needed exemption from Health Canada. We all are aware that that's no longer a federal requirement, although in Ontario, the CPSO requires that you sort of declare that you're going to prescribe methadone. There is no requirement to say that you're declaring that you prescribe Cadian, so we can all do that regardless of whether or not we prescribe methadone. But it's really the consultation with an addictions provider that becomes the more challenging piece. And so who should be prescribing this? Who should make the recommendations? And I would say that for all of us who have experience prescribing OAT in the era of fentanyl, when we're looking at overdoses and daily death rates, that if a patient is willing to go on opiate agonist therapy, regardless of whether it's methadone, buprenorphine, or slow-release oral morphine, hopefully after this talk you'll feel confident in prescribing it, because really the benefits outweigh the risk. So just as a reminder, in terms of putting SROM in the context of other opiate agonist therapy we prescribe, slow-release oral morphine is a full agonist, so it's similar to methadone in that as you increase the dose, you will have a subsequent increase in the opiate agonist effect at the mu opioid receptor. That being said, we also need to be aware that that means that we may cross over the threshold for respiratory depression more easily than we might if we were prescribing buprenorphine. We'll say more easily because I have seen it with buprenorphine, but again, it's more in the realm of methadone than compared to buprenorphine. And then obviously, routinely naltrexone is not usually used in Canada for the treatment of opiate use disorder, although it is used in the United States. So why did we kind of come up to using slow-release oral morphine? It actually has a very long history in Europe, and when I mentioned that it's been used in pregnancy for a long time, this is where some of our initial data came from. So basically, Austria, you can see Switzerland, Germany, all have used opiate agonist therapy for a decade or more. There are restricted access, so this would be like restricted to a specific subset of prescribers. That is not the case in Canada. Again, any prescriber who prescribes opiates can prescribe SROM. There's no limitations, unlike methadone, where you're still kind of, for physicians anyways, notifying the CPSO that you are going to be a prescriber of methadone. It is an off-label use. So in Health Canada, SROM is approved for chronic pain, and we will talk, I've tried to limit the number of times that I say the brand name, but the brand name we are talking about is Cadian. So it's slow-release morphine sulfate, and it's Health Canada approved for chronic pain. So we don't actually have any slow-release oral morphine products that are approved for opiate use disorder. So that is something you do need to know. It's covered under Ontario drug benefits. So if you have a patient who's under the age of 24, if you have a patient on welfare, if you have a patient on ODSP, so on Ontario disability, if you have a patient over the age of 65, or a patient on Trillium, it will be available on formulary. I'm sure I missed some there, but that's the basic gist of it. And then it is covered under non-insured health benefits as well. And if you're prescribing in a pain paradigm, they do have a limit of 200 milligrams per day. That's why you do need to have a limited use code for using it for opiate agonist, or yes, for opiate agonist therapy, so that you can exceed that 200 milligram per day limit if needed. There is no LU code, so it's covered under general formulary, no issue. So what is the evidence to do this? I'm just seeing in the chat someone asked about methadone. We'll talk about using it as an adjunct to methadone later. But basically, we have a Cochrane review from 2013 that basically looked at slow-release oral morphine versus methadone, or slow-release oral morphine versus buprenorphine. And so it was a relatively small number of participants over 3 trials, but at the end of the day, there was no difference in retention when you looked at methadone versus SROM or methadone versus buprenorphine. There was no difference in medication adherence, and there was no difference in terms of the number of urine drug screens that had non-prescribed substances. In a cohort analysis, there was higher incidence of adverse events in the SROM group compared to methadone or buprenorphine. But again, this is a very small number of studies, and this was not reproduced in subsequent studies. So you will hear people historically talk about one of the reasons they didn't use SROM was the Cochrane review showing that there were adverse events in the SROM group. However, I think we'll talk about some of the other studies that have been done since then, and this number of adverse events hasn't really been reproduced in subsequent studies, but it is something to be aware of moving forward. So this was a study that was that came out in 2015. Basically, this was not included in the Cochrane review. So again, Cochrane review was 2013. This is a 2015 study, and there were several cohort analyses that were also published. So I've kind of smushed it all into a single slide so that we can kind of look at the global data. But this was a randomized crossover trial. And had almost 300 participants. And basically they took, so in one arm, they would have taken slow-release oral morphine. They would have had a washout for 11 weeks, a washout period, and then taken methadone. And in the other arm, methadone washout period, SROM. And basically what they showed was there's no difference in retention, adverse events, or non-medical opiate use. The patients who were on SROM actually showed improved satisfaction rates, improved mental health, and no difference in physical health or a reduction in cravings. So basically both, they were considered equivocal. So this data was very important in terms of informing us in terms of using this modality for treatment, and I think was kind of one of the pivotal trials that sort of led to us in Canada, or we in Canada, using SROM as a treatment. This was the other trial alluded to earlier, which you will look at the number of participants and be like, why is she presenting that? But this was SROM versus methadone in pregnancy. It was a randomized trial of 48 women, looking at SROM in 24 and methadone in 24 pregnant patients. For a pregnancy trial, this is like an incredible number of people. For a pregnancy trial in addiction medicine, this is an incredible number of patients that they were able to look at. And basically, they showed no difference in neonatal complications, NAS, which is neonatal abstinence syndrome, or NOWS, which is neonatal opiate withdrawal syndrome, or particularly there was an issue with cocaine consumption in this patient population. So they had non-prescribed, we'll talk about the non-prescribed opiates, but basically a certain percentage of women continued to use cocaine in the pregnancies, but it was not difference between SROM and methadone. There was a significant difference in this patient population on SROM for fewer benzos and fewer non-prescribed opiates in the SROM arm, meaning that women who were on SROM in pregnancy had more urines that showed no opiates and no benzos. So the conclusions at this point were essentially that both treatments are suitable in pregnancy, both can be considered sort of equivocal, although historically that's not the way we use this data. I would say even now that's it's still considered third line in pregnancy, but it was another option prior to having buprenorphine in pregnancy. We really only had methadone, so this was a second option or second line that we could use. So this was actually quite a pivotal trial in perinatal addictions prior to some more data that we have now. I'm not sure if you want me to stop to take some questions or move on to the next section. maybe I'll just move forward and then we can stop at the end. Okay, so in terms of SROM eligibility, so we're kind of looking at how do we initiate and maintain someone on SROM in the community. So the eligibility for SROM is basically the things in black on the screen. I apologize for those who are red-green colorblind. My slides came up with red. But anyways, the things in black are basically right out of the BCCSU guidelines. So age over 19 in BC was considered eligibility if they're switching from SROM to methadone, which we will talk about, or switching to SROM from methadone. So they were on methadone and they wanted to switch to SROM, or they were opioid tolerant, like obviously actively using opioids, and then this would be third line after buprenorphine, naloxone, or methadone. They have a caveat that if you should not be pregnant or breastfeeding. So I will say that I strongly disagree with this as a perinatal addictions person. It's supported in the guidelines, so it could be considered as a treatment option for those who either don't want buprenorphine or naloxone or methadone, or have previously not been an issue. This is not in the guideline. This is also just my personal thought, but basically I also often use it as an alternate treatment to those who refuse treatment with bup or with methadone. And again, I think in the context of our current state of affairs, where we're dealing largely with patients, or at least I'm dealing largely with patients who are using fentanyl and have a high risk of overdose and overdose death, I certainly feel like SROM is a suitable option for them to use if I am not able to, for whatever reason, get them to agree to methadone or buprenorphine. So there's only one formulation in Canada, I've alluded to this earlier, one formulation in Canada that's available and suitable for opiate use disorder, or OAT. So it's the generic name being a morphine sulfate sustained release capsule, the trade name being Cadian. So this is the only option we have. M-ESLON and MS-CONTIN are not suitable, and we will talk about that in a minute. So basically, it's really important to know the mechanism of action because it works a bit differently than some of the other medications. So it contains one type of bead, but within the bead, there's two kinds of medication. So there's an immediate release, that's the IR morphine, and then there's the slow release morphine. So basically, once you swallow the capsule, it's got a hard gelatin capsule on it. So that's if they're taking it orally in capsule form. We'll talk about opening the capsules in a minute. But let's say they're going to swallow the capsule gets dissolved in the GI fluid. And basically these beads are an insoluble layer that then has pores in it that then dissolve depending on the pH. So one of the pore agents releases the IR morphine in the stomach, so they get an immediate release of morphine, and then you get the slow release pores that have to break down in the smaller large bowel. So they need a higher pH than the pH in the stomach and the acidic pH of the stomach. So the reason I kind of went through all of this is that it's actually really important when you're thinking about eligibility and who's contraindicated, because you have to have stomach acid, so you need to be able to release if you want that IR formulation released, and then you have to have a working bowel. And we'll talk about some of the contraindications for people who may have short gut or may have had a bowel resection. This may not be the best medication for them because they won't actually release the slow release component of the formulation. So it's a once a day formulation, and again, that's why it's different than some of the other sustained release products on the market in Canada for morphine. So the other thing I will say is that you will have patients who are on high doses come back and say it must not be working because they actually found the gelatin capsule in their stool. That's not unusual. So again, you really just only need enough of the capsule to break down that the beads are released. It's not unusual for people to have some kind of intact-ish looking gelatin capsules in their stool. So the administration is once a day, just like methadone, just like buprenorphine. You can swallow it whole. So if patients are on carries, they're obviously often swallowing the capsule. Although the guidelines really recommend and strongly encourage you to daily witness the ingestion, and that's usually done by opening the capsules, and there's a couple of ways. You can sprinkle it on applesauce or yogurt if they have that in the pharmacy. Most patients in the 2 cities I've worked in basically get it in a 30 cc medicine cup. They swallow the capsules and then they're given something to drink it down with. The doses available are 10, 20, 50, and 100 milligram capsules, and that's going to be important when we talk about writing the prescription. So when we talk about the doses that we need to maintain people, often we have to be a bit careful because we need to think about how many capsules someone's going to have to swallow. And that in COVID, that's been very challenging when we've had things on back order. So you can imagine a patient on 600 milligrams, if there's no hundreds available in the city, and you're having to give them tens, it can be a bit problematic. The biggest thing is that the medication must be swallowed whole, so you can't alter it. So this is not the medication you can put in a slurry or alter in any way, because again, it's the bead form that really leads to the sustained release nature of it. You need to designate on the prescription whether you're giving the slow release oral morphine for pain or for opiate agonist therapy. And again, this kind of comes down to really trying to support our pharmacist colleagues, because again, with the non-cancer pain guidelines, we have to remember our watchful doses are now around 90 milligram equivalents. And so if I'm prescribing 600 milligrams, it's helpful to kind of know, whether the patient should be observed, whether they can have carries, and whether this dose is appropriate for the particular indication. Adverse effects are basically the same as our usual opiates, particularly our full agonists. So GI cramping, abdominal pain, headache, hyperhidrosis, constipation, frequent urination, nausea, vomiting, insomnia. So this is kind of very similar to essentially methadone. It's just you're swallowing a bunch of beads basically instead of a liquid. So pharmacodynamics are very important, because remember I said that there's like an immediate release component and then a longer release component. So this is basically a study that looked at the opiate effects over 24 hours for a patient that was stable on methadone, patients stable on methadone, and patients stable on SROM. Essentially, as is typical, we know that methadone peak effect, which is what we're seeing in these dark circles, is usually around 2 to 3 hours. The peak effect of slow release oral morphine, it's showing it a bit shorter here than is typically quoted, but it's somewhere around 8 to 10 hours. So unlike methadone, particularly I'm thinking of the patient who's really unwell and you might want to see them after the peak effect and see if they're nodding off, we'd often have them come into the office 2 hours later or ask them, like, what do you feel like 2 hours or 3 hours after you take your methadone? You really need to be careful, because the lag time to the peak effect is much later. You can also see it's not as big of a peak, so you don't get as much of a high velocity to the rise, and then a drop. It's a slower velocity increase and then a reduction. So basically, think 8 to 10 hours for the peak effect for slow release oral morphine, and a shorter period for methadone. So the contraindications, as I mentioned, obviously hypersensitivity to morphine. The respiratory effects are similar, but so the SROM is shown in the white dots. So you can see, generally speaking, methadone, again, this is the similar study that I mentioned before, which was the comparative pharmacodynamics of methadone versus SROM. The respiratory effects or risk with methadone is higher than it is for SROM. So You still need to be careful though, because it's a full agonist. So the reduction, there is considered a little bit lower risk, but it's still not as low risk as, for instance, buprenorphine. So if someone has significant respiratory depression, asthma, respiratory compromise, severe COPD, these are things that you may take into account and may use another agent. Gastrointestinal, so the guidelines talk about known or suspected paralytic ileus. So for someone who's immediately post-op, that may be something that you need to consider if they're on SROM maintenance. But typically where I've seen, or I've really kind of steered clear, are those with known short gut or transit time abnormalities. Because again, you really need that higher pH in the bowel in order to really allow the medication to work. So for instance, I have patients with Crohn's disease who've had bowel restrictions. This is not a great medication for them. However, methadone in a liquid form is actually really good. So something to think about. Alcohol use, any really concurrent sedative use is going to have risks, but that's going to have risks with all of our OAT. And then MAOIs because of the risk of serotonin syndrome. So we're going to talk about SROM dosing. And so the one thing that the guidelines talk about is someone who wants to switch from methadone to SROM. And people may wonder, why would someone who's stable on methadone want to switch? So the table that's on my right-hand side, anyways, when I'm looking at the screen, talks about exactly that. They looked at a population who was stable on methadone and then switched to SROM and why they did that. So the main reasons were really they were looking for a better effect in suppressing their cravings, better effect on mental comorbidities. They had side effects under previous OAT, and they thought they might have better tolerability and wanting to try something new. So this is directly from a population that switched, and this is the reason that they underwent it. So in terms of talking about how do we do the switch, so methadone is considered basically, you have to know the equivalent dose. So an average methadone to slow release oral morphine equivalence is considered about 1 to 8. So for every 1 milligram of methadone, you're going to need about 8 milligrams of slow release oral morphine in order to stabilize a patient. But you'll remember that when we do a switch, we have to reduce by about 50% for cross tolerance. So in this example, someone is on 60 milligrams of methadone. So if we multiply 60 by 4, and I always have to use my calculator. My patients always joke with me. I didn't know going into addiction medicine I would need to do so much multiplication. I don't think my grade 3 teacher would have been very thrilled. You're going to get about 240 milligrams of slow release oral morphine. So this is how the guidelines would say to do it. And then I basically just wrote a little table. So the guidelines originally, the ones from 2017, recommended 30 to 60 milligram increases of SROM when you're titrating. So if day 1 and day 2, essentially you need 2 days, unlike methadone where initially you need 3 days in order to reach steady state, you need 2 days on SROM. So we're going to give them 240 milligrams on day 1 and 2. Then on day 3 and 4, for sure they're going to be in withdrawal. I've done this many times now, and then we'll increase them. So if you do the low dose one that's on the left, you're increasing by 30. You'll see by about 14 days you'll get up to 430 milligrams. If you go by the 60, then you'll get up to the 480 milligram mark by 9 to 10 days. So if we think that the 60 milligrams of methadone was actually equivalent more to about 480 milligrams of slow release oral morphine before considering cross tolerance, then you can see it's going to take a while for you to get up to that equivalent dose. That obviously presumes that this patient is on a stable dose of methadone, meaning that they're on a dose of methadone that suppresses their cravings, leads to negative urine drug screens, provides functionality. So you may actually have to go higher if those things are not present. So what do we expect from conversion? So again, we tend to use this 1 to 8 kind of rule of thumb. But that being said, we actually have some studies where they actually did this in Europe. So in Europe, they have 2 formulations of methadone available. So they have a, if we think back to our organic chemistry, they have a racemic mixture of D and L methadone, and then they have a formulation of methadone, which is just the L enantiomer. It doesn't really matter. Basically, just you would expect lower doses for the L enantiomer of methadone. It's very complicated, but essentially the dark dotted line essentially would expect lower doses of methadone, which would then lead to lower doses of SROM. So you can see that if they were on buprenorphine, their dose of SROM was about equivalent to 1 to 8. Those who were on methadone needed higher doses, closer to like a conversion of 1 to 12. So this just shows you that there's actually quite a bit of latitude. And again, that has to do with hepatic metabolism, whether the patient is on a stable dose, how they react to the SROM, all of these things. So again, if they're stable, they don't need to switch. But if they want to switch, these are the things for you to think about, because if you're going to do a 50% dose reduction, you need to think about what your target dose is and how quickly you need to get them there, because that might actually be the time when they might relapse. And again, for the reasons of why people would switch, there was that table that essentially said, you know, people were hoping for fewer side effects, they were hoping for a different experience, and those kinds of things. So what is more common in my world is the patient who wants to initiate, who's not on any opiate agonist therapy, and they want to start on SROM. So the guidelines for 2017 really talked about starting on day 1 with 30 to 60 milligrams of slow release oral morphine, and then titrating up from there. They didn't really get any more complicated than what you see in front of you. So you can imagine in 2017, for those of us who were using SROM, I had already had experience. So then I read this and I was like, wow, these are really like significantly lower doses than I was anticipating. And I have to say, like, I didn't look at this again until recently, when I had a pharmacist ask me why I was starting with such higher doses. And then I went back and I was like, wow, the guidelines really do say that. They say just start at 30 milligrams of SROM. Wow. So already from our talk, we already know that 30 milligrams of SROM is significantly lower than the dose of methadone we would give a patient. So why would I give this to them? So I will tell you what I do, but the guideline is this. So this slide is the guideline. This is what I do, and this is what many of my colleagues do as well. And you can see lots of different versions of this, but this really comes from the fact that I was trained as a methadone doctor. I trained in a time before buprenorphine was available, and so I tend to think in methadone equivalents. And again, I was doing this as like a second-line treatment, so I always was thinking back to, okay, if I was starting this patient on methadone, what would I do? So generally speaking, for a patient who is tolerant to IV fentanyl, so I know that they have a high tolerance, I will start at 200 to 300 milligrams of SROM as their starting dose. And so if you convert that to methadone equivalents, that's about 25 to 40 milligrams of methadone. Again, SROM is considered to have a lower risk of respiratory depression. So I feel comfortable moving closer to 35 to 40 milligrams. But again, this is kind of based on my opinion. I want to be very clear that this is not guideline-based. This is not what's written in the guidelines. I then increase every 2 days because the half-life or the steady state is 2 days, unlike 3 days for methadone. And I increase by 100 to 150. So again, this is slightly more than you would get with methadone. So the methadone increase of 15 milligrams, that's like closer to the 100. And then if I'm doing 20, which again is safer because you don't have as much respiratory depression, it's closer to 19 milligrams of methadone. And then the average doses of SROM in the literature, somewhere between 250 and 800 milligrams. I would be careful with this though, because these are we're largely heroin users. So like our methadone data that we constantly quote in terms of target doses, you're really talking about a potential for a much higher tolerant patient, depending on how quickly you're titrating them. So just keep that in mind. We don't really have any data to support what the optimal dose is for the patient who's on who's a fentanyl user. So this would be an example of a low dose and a high dose SROM titration in my practice. So if we start at 100, then by day 13, 14, so at 2 weeks, I can get, and I'm using a low dose increase, I can get to about 800 milligrams, which would be equivalent to about 100 milligrams of methadone. If you're looking at the high dose, which is 150 milligram increases, and starting at 300, it's about 1250. Missed dosing, again, like I found it really hard to look at the BCCSU guidelines because I felt like the pharmacy would always be calling my office confused, because they look at 40% reduction if they miss 2 doses, a 60% reduction if they miss 3, and an 80% reduction if they miss 4 doses in a row. I essentially use 50%. So if they miss 2 doses and the pharmacist calls me, let's say they're on 800, I say reduce the dose by 50% to 400. If they miss 3 doses, then I'm typically doing 75%. You can see, again, I'm not great at math. Or I resume their initial dose. So if I had started this patient on 300, well, at 200 milligrams, they're already below what I would have restarted. So typically in my practice, if they're missing 3 doses, they're a restart. They're going back to 300 milligrams. But again, I want you to see what the guidelines say, and then sort of what I would say is more functionally being done in the community by docs who use SROM quite a lot. And I'm happy to hear from other people who use SROM about what they're doing. Prescription format, very similar to what you would expect with methadone. Again, you need to be really clear that you're doing this for opiate agonist therapy. I write on my prescriptions, if they miss 2 consecutive doses, do not dispense and contact me for a dose decrease. And I include my start and stop dates. So the carries issue is always a thing of contention. So if you look at the 2017 guidelines, they basically said the standard should be infinite daily witnessed ingestion. Due to the challenges in monitoring for heroin use, the diversion potential of the drug, and the potential lethality for those who are non-tolerant. Functionally speaking, I would say most of the physicians that I work with work on the same guidelines as methadone. So 2 months or 8 weeks of treatment, and then with no carries, and then 1 carry dose per week every month. So Sundays to start, or whatever day is difficult for them to get to the pharmacy, and then increasing from there. So many of my patients have carries. And I think the other thing is that it's actually much easier to monitor patients on SROM now than it was when I started, because there's no heroin left. So the original argument for not putting people on carries was that we wouldn't be able to tell in their urine if they were using heroin or if they were using SROM, because it's both going to come up as morphine, right? Diacetyl morphine heroin comes up as morphine, and slow-release oral morphine comes up as morphine. But the vast majority of my patients are using fentanyl. So, and there's almost no heroin actually on the street. But again, this is just my practice. If you're strictly following the guidelines as they're written, some people are very uncomfortable with carries for SROM. You do need to be very careful about your formulations. So this has become an issue during COVID, or even pre-COVID, when we had very reduced supply of Cadian, particularly as more people are prescribing it. So the therapeutic equivalent is some people will switch to methadone, but you can't do a direct Cadian to methadone switch. You can go methadone to Cadian, but because of the respiratory risk and QT prolongation, you cannot go directly from Cadian to methadone. So if you're gonna substitute methadone because you don't have any Cadian in the community, and let's say you don't have any other formulations of morphine available, you really have to do a restart at 30 milligrams and then titrate. So even though you know there might be tolerant on a significantly higher dose, you cannot go from Cadian to methadone. You've got to go like with a direct dose conversion. You really have to go back to your starting dose and titrate. So most of us will use M-ESLON. Again, no issues with using an Ontario formulary. It's a general formulary benefit. You don't need an LU code. It's also available on non-insured health benefits. The issue is the dosing, and I've seen some really egregious errors, and it's not for anyone's fault. It's just we have to be very conscious if we're going to do this. So Cadian 400 is equivalent to 200 milligrams twice daily. So you basically have to half the dose and then give it twice a day. The issue is often what ends up happening is it's given 400 twice a day. So then you basically just double their dose of opiate. So you do have to be very conscious if you're going to do this. And typically your pharmacist will alert you, and then you can make the switch, and kind of I triple and quadruple check my scripts when I'm doing the conversion. So your options, if the person's on daily witnessed ingestion, is to have them witness the AM dose and carry the PM, or go twice daily, which is really crummy. Again, the other issue is the math, because the strengths available are not necessarily the strengths that are available in Cadian, just to make it more complicated. So hopefully we don't have to do this. Hopefully Cadian will be like available all the time, but at least I wanted you to have the information in case it became an issue, because really I think M-ESLON is a far easier switch. We know that it's morphine to morphine versus trying to go to methadone. So the final thing is I just wanted to go through a few cases in the next 10 minutes so that we can make sure that there's some time for questions and to go over things that I need to clarify for you, but really kind of look at some cases where SROM has been really helpful in managing acutely unwell patients, because often I'll get calls from community OAT prescribers who say, like, why is my patient on both methadone and Cadian, or why did you pick Cadian and not methadone? The patient was stable on methadone. So I think it's important to kind of know why we might choose one versus the other. And I have to say thank you to all of the prescribers who take the patients who have been acutely unwell into their practices, because I know certainly as an inpatient doc, I really appreciate that. So this is actually taken directly from a case report that's been published. I put the info at the bottom. So this was a case report published in 2019 by the group in Vancouver, which was a patient who presented to the ER for fentanyl-related overdose. And it's not unusual for patients, when I see them in emerge, because frankly, they've just been given Narcan and are usually very unhappy, that they'll decline buprenorphine, naloxone, or methadone. And I'm basically desperately trying to negotiate with them to go home on something, because I know that they're going to leave, they have Narcan in their system, and potentially overdose again. So in this case, they started SROM 100 once daily, and they daily witnessed it as an outpatient, and they connected them to an outpatient clinic. They increased by 50 to 100 milligrams per visit, so slower than I would do, but a very reasonable dose. And after 3 weeks on SROM, this particular patient had urine drug screens that were negative for illicit substances, and he was followed up to 6 months out and had been had tolerated the SROM super well. So I thought this was just a case report that's actually in the literature. And for those of you who might do ER or might be consulting for our ER colleagues, or have a patient who comes in with repeated overdoses and you can't get them to convince them to go on bup or methadone, this might be another option to consider. And I think these case reports in addiction medicine, for those of you who are kind of thinking about maybe I should write something up. It's super helpful because, again, you know, addiction medicine is a relatively new field. It's a very challenging field to do randomized controlled trials in, and this is actually really a breadth of information and a depth of information that we all get when we go to conferences, which we can't really do right now, and kind of talk about those success stories. But once it's in the literature, it's really helpful. Case number 2 would be a very common case that I would have on an inpatient service. 32-year-old who's currently in ER, but is going to be admitted with acute CHF. As I remember my internal medicine professor saying, what's the most common cause of you know, left heart failure, right heart failure is the most common cause. So basically this guy has tricuspid valve endocarditis, and he's basically, you know, the internal medicine staff has asked you to see them, but he's being wheeled down the hallway to go for his PICC line, and he's in acute withdrawal. The other thing they note is his QTC is 596. So that's not a great QTC for those who aren't used to looking at the QT interval. Generally speaking, we don't really want it above 500. And so that's going to impact what medications we might use. So SROM has a less risk of QT prolongation compared to methadone. Again, we talked about the less risk of respiratory depression compared to methadone, but it's still a full agonist, so it's not going to be as good as buprenorphine. SROM may be a good substitute for those who've had a good response to a full agonist and maybe aren't interested in buprenorphine as a partial agonist for a variety of reasons. One thing I really like in the inpatient setting, and that's a whole other discussion about why I like to use full agonists as opposed to partial agonists, is that you can maintain really easy and good analgesia using short-acting agents. When you're using or trying to microdose buprenorphine, at certain points it can become more challenging if they're on a lot of immediate release. The other thing is that if you use morphine as your immediate release, you can get easy consolidation to your slow release oral morphine, because it can be a direct conversion. So if they've taken 50 milligrams of oral morphine IR in 24 hours, then you know that they can tolerate another 50 milligrams of slow release oral morphine, or some percentage of that. So while he's acutely unwell and having pain and potentially thinking about going to surgery, we can use short-acting morphine, and we can basically do a starting dose of SROM. So typically how I would do this in a hospitalized setting, again, it's going to be different than an outpatient, is I would give him standing oral morphine, 30 to 50 milligrams every 3 hours while he's awake, with some breakthrough. And then the first day I would give him 200 milligrams of SROM. Basically, what I would do is every 24 hours, essentially calculate his total morphine dose and then add that to his SROM. So if we look at day 1 here, we gave him 200 milligrams of oral morphine. He got a total dose of intermediate release or immediate release morphine of 260 milligrams. If I use 50% of that to consolidate into his SROM, he's at 130 milligrams. So if we put those two together, he gets 200 of SROM plus another 130, so 330 milligrams of SROM. And then I basically decrease his IR standing dose slightly. So at the end of day 2, he's basically gotten an additional 190 milligrams of immediate release, but we just increased his SROM. So we're going to hold it for another day and then see what it looks like at the end of day 3. He used 160 milligrams of immediate release morphine. So half of that, I'm going to consolidate 50% of that to his SROM. That's another 80 milligrams. So 330 plus 80 is 410. I'm going to hold him there for 2 days and then slowly titrate up. As his pain goes down, then I can slowly titrate off the standing doses. The benefit of this is it maintains his tolerance. So let's say he leaves on day 3. I know that at least I've covered him. He's been able to ask really for as much oral morphine as he wants. So I know that his tolerance should be pretty close, or hopefully pretty close to what he was getting on the street from his fentanyl. And so if he uses, he won't overdose, even if he doesn't go home with his script. So basically I'll give you the slide because I know it's a lot of math, but I wanted you to have like a case in front of you. Case 3 is very similar, high dose opiate pregnancy, basically using IV fentanyl 5 to 6 days, 5 to 6 points a day, previously on and off methadone, not interested in buprenorphine. So this is a protocol that we developed at St. Mike's, and people are often like, well, how did you develop it? I kind of call it clinical desperation. So once fentanyl hit the street in Toronto, I was seeing tons of very unwell pregnant women that were in constant, florid, significant, pregnancy-threatening withdrawal from standard doses of methadone. And so colleagues and I put our heads together to figure out a safe way to titrate their methadones fast. And part of that was to use slow-release oral morphine as an adjuvant. Long story short, there's one case report out that's been published already that involved the use of injectable opiate agonist therapy in pregnancy, but that patient was on methadone and SROM, so that's available in the Journal of Addiction Medicine. There's a case report in Press that looks at a case report of doing this that will come out in the Canadian Journal of Addiction Medicine. And then there's actually a 15-patient case series that will talk about the protocol that we use. But you'll see some similarities to the SROM case I just talked about. I'm going to go through this very quickly, but basically what we do is a rapid methadone titration. We start at 40 milligrams and increase them by 10 milligrams every day until they reach 70 milligrams, and then we hold them for 3 days. Concurrently, we add on morphine. So similar to the SROM case that I talked about, I give them standing morphine. And in this case, because they're pregnant and opiate withdrawal is an obstetrical emergency, I never want to get called to come in to do a delivery of a preterm neonate. So I give them 30 to 50 milligrams Q2 standing while awake, plus Q3 PRNs and some other stuff in case they're contracting. But essentially what I do is very similar to what we saw in the SROM case, which is consolidate their day 1 morphine dose to SROM using 50% of their total dose, hold them there for 2 days, and then increase again based on 50% of their SROM dose while titrating up their methadone. We've probably done this in well over 20 patients who are pregnant. I've done it in many, many more non-pregnant patients. So I always feel like if I can do it in a pregnant patient, I can do it in a non-pregnant patient. But basically, we've never had a case of oversedation. Never had a case. And it's not been an issue. So in this case, the SROM is really, really helpful because we can get up to a very high milligram equivalent or morphine milligram equivalents by about 10 days in hospital. So most women are on about 85 to 95 milligrams of methadone by day 10, plus about 400 to 600 milligrams of SROM. So this is just day 7, we increased to 85 milligrams and then increased their SROM. So this would be a sample titration to show you, but by day 10, you can get up to 85 to 95 milligrams of methadone plus 400 to 600 milligrams of SROM, which is about, about 1,000 milligram equivalents of morphine. So this is just the key points. Basically, you're starting at 40, increasing by 10 milligrams every day to 70, holding there, and then adding SROM as well. These are some other things, but I basically put I didn't put the IO case report because that's a bit more complicated, but this is the Canadian Journal of Addiction Medicine case report that'll come out, and the case series is currently in peer review. So I just wanted to show you that you can kind of use the two concurrently to try and get patients with very high tolerances up to a therapeutic dose of opiate agonist therapy by using really the best of both worlds. The methadone world, which provides very good suppression at the mu receptor, with SROM, which has a little bit less data, but also a peak effect that's different than methadone. So you're not basically giving them over sedation with a really high dose of methadone at the same point. So just to summarize, basically, I've tried to review the evidence to support SROM as a treatment of severe opiate use disorder, to provide some information about initiation and maintenance support for SROM in the community. I've tried to be very clear that we have 2017 sort of guidelines to the BC SSU that initially probably pointed us in a particular direction, but those haven't really been updated. And what's happening on the ground is very different. Which is not necessarily a bad thing, but if you're really looking for like hard and fast guidelines, there's very few available. So this is really where I feel like SROM becomes an apprenticeship program where you call your favorite friend and say, do you think this is an okay thing to do? And then we talked about a little bit about the utility of SROM as an adjuvant for methadone. And I think the next webinar is by Dr. Regenstreif, who will talk a little bit about methadone in the time of fentanyl and sort of what the Metafy group is discussing about using methadone and maybe SROM together in the community in order to help with high tolerant patients. I'll leave that to her expertise to speak at the next webinar. But also for hospitalized patients and basically why, a hospital addiction medicine physician may make some of the decisions that they do. Happy to take questions and clarify or have conversations.
Amazing. Thank you so much. I thought that was wonderful, and I learned a ton for sure. I know that. I've tried to keep track of the questions and divvy them up into a couple categories because there's a lot going on. We'll read some out. Some of them are just reiteration of points you made, and some might just be some clarification if that's okay.
Sure. Yeah, that'd be great.
Great. So I think one of the first and probably easiest categories for you to hit was prescriptions. Some people had questions about.
Yeah.
One is, if an LU code is not needed, what is needed to prescribe over 200 milligrams per day?
Nothing. Like no one's going to stop you from prescribing more than 200. But if you put for opiate agonist therapy, many people will then realize that, or at least our pharmacy colleagues often are aware that patients who have an opiate addiction often require much higher doses than the non-cancer pain guidelines, where we're talking about 200 milligrams. If you're talking about non-insured health benefits, then there's basically a piece of paper that you have to fill out that says, I'm prescribing this for opiate agonist therapy. I'll need more than 200 milligrams.
Yeah, and I think there was a pharmacist in the chat that commented as well that that's helpful. So,
so generally, your pharmacy colleagues have your back, and I love my pharmacy colleagues because they've saved me more than once, many times. And so I think it's just helpful and collegial because they'll be looking at the script being like, what is this? Am I supposed to daily observe this, or is this for pain? It's just helpful so that we all know we're on the same page.
Yeah, absolutely. Another question for scripts was, should you write on the prescription the exact amount of water, example 30 cc, to dispense the Cadian in? I believe Alberta/BC recommend this as an addition to the reason for its use. Cadian for OAT is not common at all outside of larger centers. Lots of questions for pharmacists.
Yeah, so basically I just put direct witnessed ingestion and I let the pharmacist decide the best way. In BC, it's much more common to be given in something, like in applesauce or in yogurt. I've actually never, I did have one pharmacist who felt more comfortable doing that in Ontario, or at least in Toronto, but I would say otherwise my patients basically just get a little cap of their sprinkles, their beads. They take their beads and then are given a cup of water.
I agree. I'm going to jump in. I started prescribing using that, sprinkle on applesauce or yogurt. Yeah. And the pharmacy was like, what are you talking about? So then maybe you could talk a little bit about, sorry to jump in, Katie, some of the associated pharmacy issues, like someone asked, why are we opening it at all? So maybe you could clarify. Sprinkling on water versus in the cup. And then a big question that's come up is caries, and I'm sure we could talk about that a lot, but maybe you could talk about your approach to Katie and caries in general, and then a subtopic. Sorry, I'm throwing many questions at you all at once. Is the issue of caries in someone who perhaps had full or close to full caries on methadone because it was stable, made a switch to Katie, and then how would you approach that?
Okay. So in terms of the administrative details, so we're opening the capsules to try and reduce the risk of diversion. So similar to methadone, similar to buprenorphine, we want the patient who is prescribed the medication to take the medication. So capsules are easier to cheek, so kind of keep in your cheek, not swallow. So the thought is if we sprinkle them, so if we open them, put the beads in a cup, they put them in their mouth and then swallow with water, it's more difficult to keep those beads that you may want to. I mean, many of our patients all of my patients are compassionate human beings. They want to help out a friend or a colleague who is in withdrawal, and may not recognize that puts them at risk if they're not fully tolerant to the dose of Katie I'm prescribing. So we're doing this as a diversion risk reduction by giving them the sprinkles as opposed to the full capsule. I believe theoretically, and the pharmacists can, and anyone who has a better chemistry background than I do, is the theoretical risk. If it was sprinkled over water or another substance that might be slightly acidic, you may get release of the immediate release component faster. So generally speaking, I've seen it more in the context of put in a cup, put the beads in their mouth, and then swallow afterwards. But I don't think one versus the other is really a problem.
Yeah, I think people also say they kind of get stuck floating around, and then they can see the beads they're not getting, and they don't want to lose any.
Yeah, exactly. Mm-hmm. And then the second part was caries. Okay, so if someone was stable on methadone and they wanted to switch to SROM, I would probably just continue their caries as is, knowing that there's a slight risk of relapse, but most of my patients that are stable are stable. I will say that I tend to do my switches a bit differently. I tend to do it sort of on a weekly basis. I'll switch a chunk at a time. So I might switch, like if they're on 400 milligram, or if they're on 60 milligrams of methadone, I might switch 20 and give them some Kadian for a week and then do that weekly. I find it's a bit better tolerated, but that's another story. So I think if they were stable, I would just continue their caries. I think this is probably something where you're going to hear 50 people give 50 different answers about caries, but I will say that historically the biggest concern about giving caries was that you wouldn't be able to tell in their urine drug screen whether they were using illicit substances. In the era where if we have any heroin on the street, meaning diacetyl morphine, not what people call heroin, but diacetyl morphine on the street, it inevitably has fentanyl in it. So if you are really focused on the urine drug screens as a sign of clinical stability, you can feel very confident that if their urine does not have fentanyl in it, I think you can say that they are not using illicit opiates. That being said, I think urine drug screens are only a small component of what we measure when we're talking to our patients in terms of clinical stability. And I think if SROM is the best medication for my patient and they are clinically stable, I feel very confident in giving them caries.
Yeah. Thanks. I think that reflects so much about our shifting thinking around caries and looking at the whole picture and stability, and that makes really good sense. There are so many questions, but your comment about the switching in chunks versus switching over, right, I think is one that we need to come to. There were many questions. I think a lot of people thinking, well, just stop methadone and switch. And why would we do that and risk destabilizing someone rather than go down by, 10 or 20 of methadone and add Kadian, or just keep stable, add Kadian, and then begin that transition. So I know it could be another entire talk, but.
Yeah. So I was trying to sort of go based on like what the guidelines say. And so speaking to my colleagues who trained in Vancouver, it was very common to kind of do this whole switch, or at least initially. I would say that I've had very little success with that. So I tend to do it in chunks. So I tend to add on some SROM, decrease their methadone, get a sense of how it went. So if I decreased your methadone by 10 and I gave you 100 of SROM, how did you feel? Or if I gave you 60 of SROM, how did you feel? Okay, so you had withdrawal. So we know that for every 10, we probably have to give you more than 60. Let's try 100 next time we go down. And so often with my patients, we'll do that. We'll kind of go down by 10s usually. And it takes a while, but I also say to them, you know, we want to keep you stable. And most of my patients who are switching for a variety of reasons. We talked about the top 5 reasons that people switch, but it's often just a different experience. Like they've been on methadone for a long time. They have no desire to go to buprenorphine for a variety of reasons. And so they want to try something else. So I'm more in the camp of like, do it by 10 milligram increments, but theoretically you can do it as a full switch. You just really do need to take into account the cross tolerance. So I have many colleagues who were like, well, why don't you just give them the 1 to 8 if you know that that's where they're going to end up? And I think you have to recognize that we have lots of data from particularly our palliative med colleagues who've been, you know, doing opiate switches probably even longer than those of us in addiction medicine. And really the standard of care is to reduce for cross tolerance. So you really do need to do that 50% reduction if you're going to do the whole thing at once.
One last question on that, Katie, then I'm going to hand over to you. I think you explained, but maybe just repeat why it's okay to go methadone to Cadian all at once, but not SROM to methadone all at once.
It has to do with the respiratory depression risk. So methadone has a significantly higher risk of respiratory depression and death. And so you cannot go from SROM, which has a lower risk of respiratory depression. And we know that people become slightly tolerant to that, not completely tolerant to it, but slightly tolerant to it. So if they're on methadone, they're relatively intolerant to respiratory depression, relatively. So if we switch them to a medication that has a lower risk of respiratory depression, we're okay. We can switch them from methadone to SROM because the respiratory depression risk is lower. If we go from SROM to methadone, then we have a problem because the methadone respiratory depression risk is significantly higher, and there is a very large risk. I don't know what the risk is, but I wouldn't do it, and I often do things that no one else will do because of the risk of respiratory depression and death.
Thanks.
So to piggyback off of what you were saying about doing your changes in chunks when you're moving from one to another, there are a couple questions about adjunct therapy. So have you ever done or do you think it's a good idea to add Cadian on top of methadone, if we're decreasing our methadone dose for side effect reasons, for instance, QT?
Yeah, so I will often do that. So if a patient is super stable on methadone, they're like, I don't really want to go off methadone. I'll say, can you let me give you a bit of SROM? And we do that not infrequently in the hospital as well. So if someone comes in with a prolonged QT, but I know that they're stable in the community, and I know that they'll have a prescriber that will also prescribe them SROM, because that's the real issue, is that many prescribers aren't comfortable with methadone and SROM. But yes, I'll decrease the dose until the QT is fine, and then add on SROM, and then decrease the dose of methadone until their QT is okay. But yes, that's another really good adjuvant in the community for sure. So you don't have to full switch. You can just give a bit of one and a bit of the other.
Right. So follow-up question for that. What is a bit of to start the add-on for that one? Because we're not really calculating the same equivalence for that then.
Yeah. So again, if you look at the 2017 guidelines, they said 30 to 60 milligrams is like a starting dose. I usually use that as I usually use 60. So I might decrease their methadone by 10 and give them 60 milligrams of SROM. as a start. And then they might be like, Turner, I was in so much withdrawal, I was miserable, or you snow me. And then I'll be like, okay, next time we'll do 30, or next time we'll do 100. So it is a bit of playing because there is no equivalent. But I usually do a 10 milligram dose reduction in methadone because most folks can tolerate that, depending on what their dose is. Obviously, if they're on 30, that's going to be a big dose decrease. But if they're on a routine, like 60 to 120 milligrams of methadone, I think 10 milligrams is reasonable.
Right, and using those equivalencies that, 10 milligrams of methadone might be 40, might be 80. So if you pick 50 or 60 in there, you're not just putting someone in withdrawal. And I can think of a couple of cases where patients of mine were admitted with prolonged QT, VTAC, and issues. And, going back a couple of years, no one had any ideas except just take them off methadone as fast as you can, which left them with nothing. And this is just, it's such a smooth way to transition people. And to your point, why do people want to switch? I would echo that a majority of patients report feeling better. Not everyone. Yeah.
Agreed. The other thing I will say is that if we think back to, you just reminded me of the QT and reducing, the other benefit is the peak effect. So for patients who are need a higher dose because they're having cravings or for whatever reason, but they can't tolerate the dose increase, one thing I have noticed, or they have PM withdrawal, like evening withdrawal, and they can't go to the pharmacy twice a day if they're unstable. If you remember, the SROM has a peak effect at 8 to 10 hours after you take them. So a question I often get asked by community docs is, can I give them together? Well, yes, it's great because the peak effect of methadone will be 2 hours or 2 to 4 hours after you take it. And then maybe they'll get some better effect in the evening because their SROM will kick in with a peak effect at 8 to 10 hours later. So I've seen for some patients like that who really need a split dose of methadone but are just not stable enough. And so I'll add on the Cadian to kind of bump up their evening dose. Sorry, go ahead. But then they take it both at the same time in the morning, so they both get them witnessed at the same time. Often they're taking their methadone to wash down the beads, actually. So they get their beads and then they get their methadone. Yeah.
For another adjunct question, this one's a little bit different. How about SROM in addition to Sublocade?
Probably not, because you're using a partial agonist and a full agonist together. It'd be like giving methadone and Sublocade together. I mean, I guess you technically could if you're trying to titrate them over to a full agonist. But if you're just doing it because the Sublocade, let's say they're getting a 100 milligram dose of Sublocade and they're not getting good effect, I would probably just add oral, sublingual buprenorphine. Yeah,
I think that makes perfect sense with the high doses that you're getting with buprenorphine and Sublocade. Yeah, absolutely. So there's a bunch of questions. Jennifer, help me out if we're missing the important ones here. But there were a bunch of
inpatient ones. I think there are a bunch of inpatient ones. Is that where you were going, Katie?
Oh, there's a bunch of those. I was actually going to do administration questions next. But yeah, let's go to the hospital because there were some of those. Jennifer, do you want to bring some of those up?
Sure. So one had to do with post-op pain.
Mm-hmm. Yeah.
One had to do with, would you ever increase the SROM daily as opposed to every second day? And then a third one had to do with the pregnancy case that you posed, which was a quite rapid increase of methadone with morphine, but inpatient. Yet that person is still going to be discharged, right? Like you're observing them until you're not. So those are the inpatient ones that come to my mind.
Okay, so in the hospitalized patient, let's say they're on a stable dose. We'll talk about a stable dose of SROM, and then if you're initiating SROM. So if they come in on a stable dose of SROM, it's very similar then to if they're on methadone. You're going to need higher doses for pain control because obviously the SROM doesn't give them any pain control benefit. It's really just withdrawal management and craving management. So I often, again, I'm a methadone doc by training when I started, so I often think back to methadone. So how much morphine would I give a patient, or how much Dilaudid would I give a patient who's on methadone? So our general rule of thumb is, if you would give a patient 10 milligrams of morphine for acute pain who was not opiate tolerant, then I usually bump that up a bit. So might give them 15 to 20 and see how they do for their pain. But it's not going to be easy. And really, as if you are an addiction physician, or if you're in an inpatient setting, which there aren't very many of us, but hopefully that will change, or you're an acute pain doc, you really got to monitor them, because you can't really tell just by the patient what they're going to do, just like we give dose ranges for non-tolerant patients as well. So essentially, I generally think about increasing by half to double the dose for acute pain.
That's good.
If
I think you already answered the question. You would
Yeah.
not start SROM in someone who is immediately post-op as OAT. You're going to start them with short acting, I would imagine, and then convert. Yeah.
Unless they're in frank withdrawal on top of everything else. So in those cases, I might, because I need such high doses of short acting to get them under control, but I might do it in a different way. I might do it in a split dose regimen, because that actually has an analgesic effect as opposed to withdrawal management. So let's say I might start that patient in the community, because they use 10 points of fentanyl a day. I might start on 300 milligrams of SROM in the community. I might give it 100 TID so that I can get some analgesic effect from it. They're not in withdrawal, and then I can actually treat their pain. The problem is, if they're in withdrawal and you're trying to treat their pain, it's a recipe for disaster.
I'm going to keep asking a question on that theme. Sorry.
Yeah.
You've got someone who is post-op, let's say NPO. This is sort of piggybacking on one of the other questions. So their opioids are going to be sub-Q, I assume, and then looking at transitioning. Any thoughts around converting from their sub-Q doses of morphine or hydromorphine as you go to oral and to SROM to get them ready to go out?
Yeah, so you can convert them. So it's easier if they're on morphine, but most patients in modern hospitals are on Dilaudid, so it becomes more challenging when they're on hydromorph. So then you have to reduce for cross tolerance and then consolidate. So it's a bit of it's just lots of messier. So it's twice as strong IV sub-Q, generally speaking. So, let's say they're getting 4 milligrams IV Q3. I would figure out what their IV dose is, then double it for their PO dose, and then take some percentage of that and give it to them as SROM.
Right. So there's a little plug for if we could just get those patients on sub-Q morphine instead of hydromorphone, but it all works.
Please. It makes my life so much easier.
Katie, go ahead.
Sure. So for some administration questions, so these ones should be pretty easy, I think. There were some questions about the GI absorption that you'd mentioned. So patients on PPI and any information for patients that have had a gastric bypass. So we'll start with those.
Bypass is essentially a no. We don't really know, but we know from the other kinds of gastric surgeries that it's probably not going to be a good choice. I'm not going to say no, but I think you would want to talk to their GI or their surgeon. It's probably a no-go. PPIs is fine. Don't worry about the PPI. And we're really worried about the long-acting component of it. So, the amount that's going to be the immediate release is negligible compared to we really want the sustained release component. So even if they're on I have some alcohol patients who are on 40 of Pantaloc BID for life, I'll still give them SROM. I just hope that they continue to take their PPI.
There were some, I hope so. There were some questions about NPO patients and then the formulation. So one was, is there a syrup available for the immediate release, I believe? And then the other one is, are the beads crushable?
So you can't crush the beads because that messes up the pore structure that then releases it. Some patients will inject Cadian. Telltale sign is that they come up with a very severe candidial infection as a result. For some reason, something about the beads grows fungus, and then they get I'm not an ID doc. I'm sorry for like my ID colleagues. I think I saw a few of their names. Anyways, I apologize. But basically, there's some telltale infections that patients can get that's clearly from injecting Cadian. And so in those cases, we generally have a conversation about like, how can we help you? Is the dose too low? Like what kinds of things would work? NPO patients, I have to say, like in my career, it's been very rare where I can't give a patient at least something with a sip of water. So, methadone, usually we can give undiluted if we have to. It tastes terrible, but they can have their methadone undiluted. So essentially I would just give them their beads with like a bit of water. The problem is that post-op, you're going to get a paralytic ileus, which may actually impair their absorption of the beads, right? They need the bowel to be moving, and then they need a specific pH for these pores to open up. So in the post-op patient, I still give it to them, but I also know in the back of my mind that, and this is true of all opiates, because the absorption isn't great when you have an ileus. I know in all my patients, they may need higher doses for pain control and for withdrawal. So essentially it comes down to believing your patients that if they say they're in withdrawal, it may be due to the gut motility.
Okay.
I think a really important question that's come up is, especially if you're in, a RAM or an inpatient setting, what to do if you're interested in starting SROM and you're not sure who's going to take on that patient care. And I would say, hopefully this webinar is, the beginning of building knowledge and capacity. But have you found that to be difficult? Have you made certain arrangements? Has that ever impeded you from deciding to start someone at SROM, fearing that you weren't going to be able to find them a provider who would continue their prescriptions?
So for sure, it's challenging. I mean, back in the day when, I was doing this for pregnant patients and everyone thought I was crazy, the solution was that I just took all the patients on myself as outpatients, which is not sustainable or doable in the long run. And then I found some very lovely, funded colleagues who I was like, I'm desperate, I need to take I need to take on another pregnant patient. This patient is postpartum. Can you please take them on? So it was a lot of begging. I would say, generally speaking, we try and develop good relationships with our outpatient prescribers, and we'll often call them, or if we're doing a switch for some reason, we try and contact them. At the end of the day, as an inpatient doc, if it's the best thing for the patient, I'm going to do it, and we will all just call and beg until we find someone to take them as an outpatient. It just would be nicer if it was easier for people. And so again, as you said, this is hopefully a start to that, so that it won't be so scary or such a big barrier. And I think part of that is just being around for colleagues if they have questions, how do I titrate this, or this patient missed doses, what do I do? Because it can be confusing.
Mm-hmm. Yeah. Wow. I think there are many more questions. We could go on, but we actually have to wrap up. I imagine that people will be anxiously waiting for these slides, that there will be conversations on the listserv. And I am so glad that we wisely thought to put your talk this month. And then next month, a chance to respond to many of the questions that came up around adjunct therapy and combining, and so many of the opportunities and challenges around there.
Great. Thank you so much.
This was really, really great, Suzanne. Thank you. I apologize to everyone who didn't get their questions answered. I think I'm going to offer, not for everyone to email you, Suzanne, but to keep conversations going, at least on the listserv. And perhaps this is a topic that we should revisit, especially around some of the key themes that came up for us.
Great. Thanks.
Amazing. Thank you, everybody. Do not forget to fill out your evaluations, please. All you have to do is click on the red button at the top of your screen. That makes it really easy. The webinar will be posted onto the Medify webpage within the month, we hope. And I don't know what to tell you about the certificates for credits. That's to be determined, but anyone who participated obviously will be eligible, and we'll stay tuned about whether those are coming out after each session or at the end of the series overall. So thanks again, everyone. Have a great night.
Thank you so much.